From coast to coast, continent to continent, this is Bone Talk on WPSL with Dr. Joe at one location, Dr. Ed at another location, as FOS keeps exploding on video. Good morning, doctors.
Good morning. And how about that? We are real professionals with this audio video equipment now. We got Dr. Southard at our clinic in Stewart off of Highway 1 and Indian Street. And I'm Dr. Wiersbecki, and I'm at our primary location in Port St. Lucie off of Highway 1 and Walton Road. Yeah, we are on, what is this, Greg? YouTube TV. We're on the AM radio. We're on every platform, it seems like.
And, of course, you're on our stream, too, which is probably... who knows? I've got to get the up-to-date stats, but I know that our IRSC final game was listened to in 80 countries. So, wow. Yeah, the stream is what's totally ridiculous. It's wonderful. And wow. And then, of course, this, which is being recorded on our Zoom, is going to be put on our YouTube television channel. So, yeah, you guys are everywhere.
Nice.
Great.
And I'm glad you've got the cameras going and everything. People want to see you. That's what the deal is.
Well, we're coming to you live from Florida Orthopedic Specialists. Again, if you want to see us in clinic, my partner, Dr. Southard, or myself, Dr. Wiersbecki, telephone number for Florida Orthopedic Specialists is 335-4770, 335-4770 if you want to see us in the office. And of course, if you want to call and have your question answered live on air by Dr. Southard or myself, Dr. Wiersbecki, it's 340-1590 for Bone Talk, 340-1590. And like Greg mentioned, this is our first show on Thursdays. So for a long time, we've been on Wednesdays, but this should be our permanent home. What are we doing it, Greg? So Thursdays, 10 to 11 is what it is?
That is it. And of course, you had some... changes in surgery schedules and stuff at St. Lucie Medical Center. By the way, hats off, guys. You are operating in an A hospital, the only A hospital on the Treasure Coast, St. Lucie Medical Center. So that
has it always been that way? Is this new news?
No,
it's like old news.
Yeah, well, it is. Actually, it does seem like old news for St. Lucie Medical Center, but it's the leapfrog studies that were just released on Wednesday. So congratulations to St. Lucie Medical Center. And of course, you doctors operate out of there. So that's cool.
Great. Yeah, they're maintaining their A grade. Yeah, it's outstanding.
Yeah, and that's, you start thinking about that. That's as consumers, that's, people really, look at stuff like that now, where before, I guess you never even would consider stuff like that.
Yeah, but I forget what they call them. There's certain centers of excellence, specifically when it comes to certain procedures, certain fields. And I know for the longest time, they've been a center for excellence in orthopedics. Maybe it's the whole hospital now too, but do you remember what they're called, Dr. Sutter? Are they a magnet hospital?
Yeah,
or are they...
So Magnet Hospital is the premier award that a hospital can be given. And the unique thing, I mean, I'd have to really dig into the research to what it means. But when you get recognized as a magnet hospital, it's not just the docs and the nurses. They really have strict criteria. Even the custodial staff, the kitchen staff, there has to be a full gamut of satisfaction amongst the employees, amongst the patients, and like Greg just said, as much as we don't like to think about it, in reality, patients are also consumers at this point because they can choose to go wherever they want within reason. But for the most part, you have the luxury of doing that. It's one of the beauties of medicine in this country. But if you reach magnet level status, that's an achievement because that's basically saying across the board, you have reached the pinnacle of patient care.
Well, wow. Good news, guys. You have been followed to Thursday by Jerry. Jerry, good morning. You're on with the doctors.
Thank you, Greg. Good morning, doctors. I was wondering, Dr. Joe explained Shane Stokes respirations, but when we were given a directive to check a patient's vital signs in 3 different positions, and I understand posh weight, means the patient's laying flat, posh weight, and then standing up and sitting down. And what I was wondering is Is that what you usually notice? Shane Stoke phosphorus when the patient prostrate, or they're laying flat on their back, doctor. Doctor, I'd like to listen off air. If that'd be okay.
Yeah.
That'll be fine. I mean, I don't know about you, Doc. I'm not quite sure what that first term that he's referring to. I can tell you, the theme of what he was discussing is something that we know as orthostatics, and you need to check the patient's vital signs in multiple different positions to look at various etiologies. It's a little out of the bounds of orthopedics. But for, cardiac, for example, a patient may be wanting to checking their blood pressure, their heart rate in a supine or lying down, which that may be the POSH statement that Jerry was talking about, and then in a seated or a standing position as well. So if you're hypovolemic or you're dehydrated, if you have some valvular disease that's limiting the outflow of your heart, there's various different ways that you can have normal vitals when you're lying down supine at rest. But as soon as you stand up, your blood pressure can drop significantly, your heart rate can jump significantly, and that's to overcome an all of a sudden lack of flow to the brain. But what we, at the end of the day, the body is maintaining a homeostasis, and it needs to get blood and oxygen to the vital organs, and the body's view of the vital organs are the brain and the heart. So everything relies on making sure that your brain is perfused. So if I am lying down and I have a normal blood pressure and that gives me a normal heart rate, I stand up because I have low volume, I'm dehydrated. All of a sudden my blood pressure drops significantly. My heart has to speed up to maintain that perfusion to my brain. And that becomes something we call orthostatic. So that could be what he was tying into, but yes, it's done regularly.
I thought I heard him say that Cheyenne Stokes respirations, kind of that abnormal breathing pattern that you could see with any number of things. If someone has a brain tumor, if they have fluid in their lungs, if you all of a sudden go to a high altitude, you could develop an abnormal breathing pattern while your lungs adjust. And so if my memory back from medical school was Cheyenne Stokes respirations are an abnormal breathing pattern, and there can be a few different causes of it. For the most part, when we're sitting still, doing our normal everyday things, our respiration pattern should be more or less the same, very minimal irregularities. So if something is not going right, and of course, this is unconscious breathing, breathing that you're not trying to control. And so if you have an abnormal breathing pattern, that could be a sign of something else. Most often an abnormal breathing pattern is because you become aware of your breath or you start some kind of physical exercise, and then that's going to, of course, change how you breathe.
But I think you touched on something just a second ago where high altitude, say Denver or, any of the Rocky Mountain states could change your breathing pattern too. If you're coming from sea level, I would imagine, right?
Sure. There's less, there's less oxygen concentration up there. And so in order to get more of that, you need to breathe a little bit faster. What other people don't kind of appreciate about the body too is the lungs do so much more than just, bring oxygen in and carbon dioxide out. They're doing this amazing job of helping us to acutely balance acid base, your acid base percentage in your blood. If something's going wrong in your body, maybe there's a kidney issue, then your lungs are going to help you acutely accommodate for that so that you maintain a normal acid base balance. Because if you don't have a normal acid base balance, your tissues can degrade very quickly and die, and you can die. And Dr. Southard, of course, can speak to this with his anesthesia background. During surgery, your acid-base balance is going to be different. Your kidneys are going to be different, and your lungs, you need to control oxygen, carbon dioxide, and how quickly you're doing so in order to regulate acid-base balance. If I remember right, Dr. Southard, when you blow out, if you are to hyperventilate, you get rid of more acid from your body, and so then when you get rid of more acid, your blood kind of acidity decreases if you were to hyperventilate. Am I remembering that right?
So if you blow off, so it's everything is like I said, based on acid base, and when you look at it, the acid is a positively charged hydrogen ion. So if you blow off more CO2, you're blowing off the associated hydrogen ion that's associated with it. So as you exhale acid, your pH actually goes up. Your blood becomes less acidic because you're blowing off what do you call it? You're blowing off the hydrogen ion, you're blowing off the carbon dioxide. So for example, if you become acidic, say you are having some type of renal abnormality, and there's a huge interplay, and that's where our nephrology experts and our pulmonary experts are real experts at this. The kidney and the lung, like Dr. Wierzbicki just tied into, has an amazing interplay maintaining acid-base balance and homeostasis. We live in a slightly acidic environment, pH less than 7.4, but you need to maintain that range. If you go much more than beyond 0.2, 0.3 of norm, the body needs to adjust accordingly. So whether I slow down respirations to maintain acidity in an acute environment, whether I blow off hydrogen ion to decrease my acidity, increase my pH in an acute setting, and then the kidneys are able to compensate, by increasing or decreasing bicarbonate secretion. It's a really complex interplay, and I'm so far removed from it to actually I can talk about it over the air, but I wouldn't be able to teach medical students about it right now. It's just an amazing interplay. The whole body itself is amazing interplay. We're at the luxury of treating orthopedic patients, sports medicine-based patients, but basic homeostasis, acidity, that affects bone healing. Patients that don't have the right balance, they don't have the right milieu of, base versus acid, then you can't have hydroxyapatite formation in the bone. And it really gets complex over time. Your osteoclasts, which are the bone resorptive cells to chew up bad bone so your body can make new bone, they need acid. If you know what I mean. The interplay of all the systems is quite intricate.
And actually, a normal transition here would be to talk about the effect of tobacco's effect on the lungs, blood, when it comes to healing a fracture. We talk about it all the time. Someone comes into the office with a broken wrist and we see, oh, you're a smoker. Okay, well, now is the time to quit because, you can have these certain benefits immediately. And yes, long-term too. But if I remember right, Dr. Southern, you could probably quote better numbers here. Even in the first few days or few weeks after quitting smoking, it changes dramatically your ability to heal, if I remember right.
Ilia does go up approximately about 2 to 4 weeks after quitting smoking, or at least decreasing that smoking. Now, I'd have to pull up the paper and look at the numbers, but we're talking significant decrease, though. If you're a 5 cigarette per day smoker and you drop down to 2, that's something, but you're probably less likely to see any significant improvement. Whereas if you're a pack per day and you drop down to a half pack per day, or you drop down to no pack per day, it's a really hard conversation to have with patients, especially in a fracture type setting. Elective surgery is a totally different story. Nobody has to, I think we talked about this in the past, nobody has to have elective surgery. What is elective surgery? Joint replacement, knee arthroscopy, ACL repair, rotator cuff repair. These are real problems that real people face, but it's not an emergency. Somebody walks in with a shoulder fracture, that's, a smoker. I have a patient that's, that I've seen in the not so distant past. He's had a fracture for 5 or 6 months. This poor man has zero signs of clinical healing. One of the things that is affecting his healing is he happens to be a pack per day smoker. He's probably never going to heal. At the same time, he's probably never going to use his arm again. So it's a real challenge as a surgeon to face. If I want to help him, I would love to fix him. I need him to get on board. We all need patients to get on board to do their part. And sometimes their part is cutting back smoking, improving their diet, cutting back on alcohol use, cutting back, getting your diabetes under control. I won't do arthroplasty, joint replacement on a patient with a BMI over 40 or a hemoglobin A1C over 7. If you don't have your diabetes under control, your weight under control, I'm putting you at risk of infection, failure, so on and so forth. So it's, there's a lot of things that patients need to do in elective surgery model to negotiate their care to make it appropriate care. But smoking is a big one for fractures because, what do you do with what we call an atrophic non-union? So no clinical signs of healing to a bone, despite the fact that they've had surgery on it. I've made that person no better. In fact, if they may get infected, now I'd make them worse.
And you mentioned elective surgery. So I know there are some specialists and some procedures out there that that they will check a nicotine level prior to surgery. I know spine surgeons do it. Some plastic surgeons will do it. Are you familiar with what procedures and what fields do that? Do you know much about that?
I think it's selective. It's there's literature supported that nicotine includes healing. I haven't quite made it part of my practice yet. I probably will at some point. It definitely was more of a part of my practice when I was up north, because we had a different population of patient. Not better, not worse, but I feel like the patients down here, we're a pretty active population down here. And while yes, there's probably you notice the smokers down here more because they're able to do it outside and they're in the restaurants, whereas in New York, they were nowhere to be found. They were like secret clubs of smokers. But it's changed dramatically in my lifetime. I mean, you and I are pretty close to the same age. I remember the time when you'd roll up into a hospital, you'd have to walk through the entrance to the hospital with the doctors and nurses all standing outside smoking cigarettes at the entrance to the hospital. Good luck finding an ashtray in front of the hospital now. It's nowhere to be found. And that's just not hospitals, it's everywhere. I mean, there is an attraction to smoking, apparently. It's not something that I'm into, but people have really started to take notice of the deleterious effects on their health, and they're coming up with alternatives.
Now,
do you guys
Greg.
ever run into patients who say, well, I quit smoking, I just smoke cigars? or pipes.
That's on our intake form. Do you smoke? And then what is it that you're smoking? Is cigars? Is it a vape pen? Is it marijuana? Is it cigarettes? So we'll just kind of see that evidence there, and we counsel people a little bit more about that when there's a bit more of a high risk condition at play. Yeah.
Okay, so no matter whatever you do like that, that puts you in a high risk category.
Yep,
higher, exactly. I mean, nicotine poses a risk. It's everything in moderation. I mean, people, like Dr. Wiersbecki just started to try out. Vaping has its nicotine effects too. So if you go from a pack a day smoker to the equivalent nicotine amount in a vape, you've done yourself no good. Except, instead of smelling like Marlboro or a Newport, now you smell like some scented oil that you chose of your liking. It's still the same thing. And the same thing with cigars and pipes and so forth. Yes, there's a lack of inhalation effect with the puff, for example. A cigar, you inhale, you don't technically inhale all the way, but there's a secondary smoke effect because you're still breathing in the same room where you're exhaling the cigar. So you might not be taking a puff and bringing it all the way into your lungs, although I know plenty of people that do that. It's just none of it is good if you don't do it in moderation.
Yep. And remind me the vascular effects, so how it actually affects your vascular system, your ability to heal nicotine and smoking. Originally, in the first few weeks, is it because our blood vessels are able to dilate more in the extremities and closer to the actual cells that allows for? Is that the reason why we get some improvements initially early on, but then long term, it's a different mechanism when the smoking and the nicotine is allowing your blood vessels to be more flexible with better elasticity? Do you remember that exact mechanism for how it works?
So nicotine is a vasoconstrictor. When you inhale the nicotine, it constricts your blood vessels
tinier.
So you're in a chronic state of decreased, decreasing the diameter, the inner surface area, the lumen, so to speak. I mean, think about it. For anyone that goes to a restaurant or is a coffee drinker or an ice drinker, whether it be a fast food restaurant or so forth, and then think about the small cocktail straws that you get when you go to a social event or a bar or whatnot. So you have the same amount of liquid in a cup. Take a 16-ounce plastic cup and I try to drink with a normal, say, McDonald's size straw. Now I turn around and I take that same 16-ounce McDonald's size cup and I try to drink through a little short cocktail straw. That's vasoconstriction. So
Yeah.
you have this vasoconstriction. Now I can't get that blood volume, into my mouth, AKA my bone, to heal, and it becomes a chronic problem. Bone needs nutrients, blood, oxygen, glucose, just like any other system needs blood, your brain, your heart, and so forth. So if I can't get blood to my body because of vasoconstriction, I am at risk of non-union. And then the secondary effect over long-term effects, the endothelium and the interstitial tissue in the blood vessels, because there's 3 layers to your blood vessels, they get hardened. So if they get hardened, you lose the elasticity. So now they don't have the ability to then vasodilate. You live in a chronic state of almost vasoconstriction. And that's the secondary effects of long-term smoking. And truth be told, also the secondary effects of things like uncontrolled diabetes and so on and so forth. All of these disease processes that we talk about, smoking, diabetes, cardiac disease, they're all small vessel disease. They're diseases of blood flow. There's very few diseases out there that are not blood flow related. Alzheimer's is one. Lack of blood flow to the brain, you cause brain degeneration. Atrophic non-union of a bone, diabetes, heart attack, myocardial infarction, so on and so forth. I mean, the list goes on and on and on and on. I can't get blood to where I need it to clean out my system. And, it's obviously way more complex than that. But, if you can't get blood and nutrients to a body part, there is going to be some kind of dysfunction in that body part, likely.
Yeah. I'm trying to think of it right now, conditions, outside of, an isolated cancer or they're pretty much all of our conditions, are in some way related to blood coming in and blood going out, whether it's an electrolyte issue, a hormonal issue or whatever. All of our other conditions tend to be affected by these. So yeah, it's a pretty short list. Yeah. You need a properly functioning cardiovascular system,
Right.
Well,
cardiopulmonary system. Let's say it that way.
I've got a question as far as, you just touched on the word cancer. Somebody who's gone through chemo, doesn't that throw everything in your body out of whack?
No, that's a good question. I've been meaning to look into this further and talk to some other docs about this. But and Dr. Southard, in patients who have, let's say that they've gone through chemotherapy and radiation therapy in their like upper lung, close to the shoulder region, how does that affect the orthopedic anatomy if they've gone through chemotherapy, radiation therapy? How does that change things in its general vicinity? Do you have a good pulse on that?
I do not regarding chemo. We should hopefully, one of these days, we could have one of our musculoskeletal oncologists join us for a conversation like that. I will tell you, radiation is kind of the devil of surgeons. Most radiation has some level of scar tissue formation. So, for example, breast cancer patients or lung cancer patients that are non-responsive to chemotherapy that have to undergo radiation, there's a significant amount of scarring of the chest wall, the pectoralis muscles, that goes into the axilla. And a lot of that is a blood flow related issue. The radiation, can scar down the blood flow. It can decrease the amount of available blood for healing, simply because the whole idea of radiation is to kill cells, and you want to kill cells by necrosis. How do you get necrosis? Lack of blood flow. That's exactly what we're trying to do. We're trying to kill cells because of lack of blood flow. And unfortunately, some of the local tissues, they're way better at targeting now than they used to be. But there is some after effect of soft tissue compromise in the local area. So I don't have an experience with a patient having a similar problem that needed surgery. But if venture to guess, if the patient had significant radiation where they're having scarring in their chest wall and axilla, they're probably not a good candidate for an elective, say, shoulder arthroplasty, because the likelihood that they're going to have poor healing, possible infection, or other sequelae of negative compromise after the surgery is pretty high.
Even a ways after having that, or is this just a certain time period where they may have some addition, or where they may be more at risk for certain adverse events? Again, I'm not a radiation oncologist, but
okay, a lot of times the scarring is permanent. There's enough residual blood flow to allow function of the body, so the tissue as a whole doesn't die, doesn't necrose. just the isolated cell that's being targeted. And, and they're masters at this. They've been able to find correlations with, what radiation level will kill what cell they're trying, what cancerous cell they're trying to target versus maintaining healthy tissue. But, there is some level of damage that occurs with radiation. I mean, we live in Florida. Anyone who has a sunburn knows that radiation is bad for tissue. Now, rev that up, X amount factor because you're trying to necrose cancer cells. Yes, the body has an excellent way of healing and resolving, but usually scarring from radiation is permanent. Be it minor, be it major, it's usually permanent.
So when you're talking about getting radiation in the chest area, whether it's for like a breast cancer, a lung cancer, you as an orthopedist are a little bit more concerned about scarring of the soft tissue of their pectoralis muscles, of their shoulder blade muscles, of the deltoid. And so, am I hearing you right that it's especially important to do soft tissue work, do some physical therapy in order to try and prevent that side effect? Am I hearing you right there?
I would say probably, again, still defer that to our oncology experts. From an orthopedic standpoint, the usually time we only really see radiation being used is for chondrosarcoma or various cancers of the cartilaginous surfaces, because a lot of times the radiation doesn't work. And there are some bony tumors, Ewing's can respond to cancer, chemo and radiation. But those are usually diseases of younger patients. You don't see Ewing sarcoma in older patients for the most part. But like think your osteosarcs and so forth, those really get treated by chemo plus minus surgery, and then usually another round of chemotherapy afterwards.
So Dr. Southard, so you're a shoulder specialist expert. So cancers that go to the shoulder, metastasize, for those people who don't know that word, means go from one location to another. Is the most common cancer that's going to go to the shoulder going to be lung and breast, or do you see any others at the top of that list?
Interesting enough, cancer can go anywhere. Metastases are metastases. That's the definition of metastases. It leaves the local area and travels around the body. They tend not to go to extremities, to be honest with you. Most of your cancers that metastasize, they go to your inner table of bone, where they go to the pelvis, they go to the spine, local tissues like that, because that's where a lot of the blood return is, right? So, the blood goes out and the blood comes in, and it winds up traveling into the various venous plexuses that surround, say, the spine, the venous plexuses that surround the abdominal cavity and the low pelvis. And that tends to be where you see a lot of metastases. You can see primary cancers in the shoulder and elbow, knee and hip and so forth. But I have not seen too many metastases, into the bone itself, extremity wise.
Yeah, the few that I remember that kind of stand out a bit more were some breast cancers, and then just a kind of odd collection of them, but nothing that really stood out. I've just noticed more breast cancers to the shoulder than any others that I've seen.
And that's usually secondary to the lymph node drainage. You get the lymph drainage from the breast goes into the axilla. And then if you get a little bit of spillage from the cancerous cells there, and the same reason, the vascular network, because it's, there's a huge collateral circulation around the scapula and the upper extremity. So you could, in theory, get some drainage from the axilla breast that goes into one of the tributaries that are coming from the arm. And it does happen for sure. Less common, but it can happen.
And thinking about, cancer and radiation here, the radiation's effect on the other things in that area, blood vessels, nerves. I'm guessing the radiation, we can see similar effects in how it's going to damage and scar things. And then that may cause some other issues in the arm, for example. Just thinking out loud, just to tie a bow on that topic.
Yeah. Cancer is a big topic. That's why we have, multi-center specialties. I think University of Miami is probably the closest, cancer, tertiary cancer center to us. And I think the next stop north is going to be Gainesville. If I'm missing one in between. From an orthopedic standpoint, one of our classifications of orthopedic oncology is Dr. Enneking, and he was a professor at University of Florida in Gainesville for, years. I'd have to say probably at least 20 plus years, if not more. And they have one of the best orthopedic oncology fellowships in the country.
Oh, yeah. Yeah. Wow. Good topic. Number for Bone Talk, 340-1590 for Bone Talk. Third time's the charm. 340-1590 for Bone Talk if you want to call and have your question answered live on air. Of course, if you want to see my partner, Dr. Southard, or myself, Dr. Wiersbecki, in clinic, the telephone number is 335-4770 for Florida orthopedic specialists.
Yeah, and I think this is our first show zooming in from both locations, which is kind of cool. Of course, Dr. Ed is on the south side in Stewart, and Dr. Joe is up north, and you see each other, and it's just like sitting together. It's kind of cool.
Yep. And we should have Dr. Sellers on again soon. With this being the first time back, he's still adjusting his schedule, but I think in the future, you'll see Dr. Sellers and I at this location. But I bounce around a little bit on Thursdays. And so every now and then it may be both of us in Stewart. So we'll have a nice little mix, hopefully bring a little bit more variety than I've been able to do in the past. So I'm excited about it.
Yeah, it's a good experience. It's, it brings to light, the various locations that we have. And it's also pretty amazing, the technology that we have. If you think about it, Zoom has really changed the world. I mean, being able to have meetings from across the way, visualization, conversation, being able to get visual aids to various people, it's changed quite a bit. So
yeah, and I think down the line, you guys need to think globally. I mean, if there happens to be a shoulder expert that you really want to get on from, say, a Chicago or a Los Angeles, something like that, it's very easy. They can just join your Zoom. So yeah, that's the one gift I think that we got from the pandemic. Although I was using it, for IRC basketball long before pandemic, is Zoom and the quality of Zoom now. Yeah.
Yep.
And
that's a great idea. Get some guest speakers. I know Dr. Wiersbecki, I'm sure you do. I have a ton of mentors and colleagues of mine in my shoulder society that would love to come on, and they spend as much time on Zoom doing meetings and talks as they do in the OR. So it's been able to get access to experts across the board that we didn't have access to before. You had to fly across the country to see somebody. Now I can put a PowerPoint up and broadcast it to the world. Dr. Powers has given lectures all the way over to Russia, from his office, talking about the modernization of anterior hip and adaptations and changes in stem implant techniques and design. So it's pretty impressive.
Well, Greg, we've been talking about it for years, but I'm finally going to get my wife on next month and do a medical dental bone talk. She's having the repeat C-section at the end, that 31st of this month. And so she'll be recovering at home. And so, the C-section recovery, it's, it really just gives you an appreciation for how intense that is, when you're cutting through certain muscles down there in the abdomen. And so while she's kind of getting geared back up, I'm going to get her on Bone Talk, and we'll talk some medical dental stuff, osteonecrosis of the jaw, osteoporosis treatments, and how maybe it affects dentistry and the crossover.
Yeah, I think that's fascinating, and that would be neat. Yeah, that's very good. And someday, and I know that, whatever, 15 years ago or whenever we had Dr. Powers on, but it's been such a long time since we've had him on. That would be a treat as well.
Yeah, Dr. Powers, I think the last time he's been on here was probably 6-7 years ago. I remember there were a couple politicians who Dr. Powers knew, and we kind of talked with them about the state of healthcare and the direction it was going. It was right after, I want to say, Obama left office, however long ago that was. And they were talking about the transition of Obamacare and the health of just our medical system. So I think that's the last time we had him on.
Yeah, we got to get him back. And Daniel's with us from Port St. Lucie. Daniel, you're on with the doctors.
Thank you. Good morning, doctors.
Good morning.
I wanted to start off by mentioning I've been to your facility many times, and your therapy. And And matter of fact, Dr. Sellards has replaced both of my hips, and your therapy has been wonderful. But I was wondering, are you aware that your therapy department will not accept prescription from another doctor without going through your doctors first?
Yep. So it's one of these Medicare health regulations in the way that our physical therapy unit meets certain
Well-
criteria and is classified. That it can only have a certain number of physical therapy orders coming from non-Florida orthopedic specialist doctors. And so we're constantly keeping an eye out for that. And so we can take them, but just in a limited amount. And so I think it has to be less than 10% of the outside doctors' orders coming in for our own physical therapy for us to meet certain quality measures. And so if we're on the wrong side of that, then we have to wait. And if we're on the good side of that, then we can take a few more. And so it's just one of these weird things about our healthcare system. Sorry about that.
I think we
Okay,
lost him.
I guess we lost Daniel. I
it's
thought
a-
he was still on the line. That
It's a good
that-
question.
Boy,
And
that's a Medicare issue again.
it is, and it's just one of the difficulties of our healthcare system, and it stinks, because obviously any physician can prescribe a physical therapy order, and there's also weird things. Sometimes across state lines, a Florida doctor can't prescribe physical therapy in another state, and so it depends on the exact physical therapy unit, how exactly they're classified, and then again where they're at with certain numbers, and so. It's an odd, weird thing, but that's our system.
Okay, now I've got a question. With both of you working as you do with a lot of snowbirds, and you're working, with rehab with them, they can't take that prescription up to New York or Boston?
I rarely have problems with it, but I always warn people that depending on the state that they're going to and the exact physical therapy unit that they're trying to go to, that there could be a problem. So I always just kind of bring it up, and it's more rare, but it happens.
Yeah, I think to my standpoint, because I'm obviously more operative than Dr. Worsbecky is, I go out of my way to make sure that they have established care at the place they're going. Now, fortunately, for myself, especially if it's a shoulder upper extremity place, I have a vast network of colleagues that work around the country that I'm on professional societies with or meetings with or whatever the case may be, that are just a phone call away. Or quite often the patients have orthopedic care, back home. So they have access to them, so I've gone insofar as calling surgeons and saying, hey, look, I've done this on patient X. Can you just keep an eye on them for the next 3 to 4 months if something comes up? And they're usually people are pretty reasonable to assume care. And the same goes for us. When I have a patient that comes down that's post-care from somewhere else, and I know they're going to be here for a 5-month period, they may have to come in and have a consultation with one of us, but then we can very easily just give them a prescription to physical therapy. Is it a minor inconvenience for them to do that when they get here? Yeah, possibly, but then you look at it on a positive side of things. If you're going to be here for 6 months, you probably don't want to be coming down here or going up there with one physical therapy prescription and then wait 6 months to see a physician or the physician that prescribed it to you. But what if the therapy is not going well? What if the therapy is going great? I mean, if you're doing great in therapy, who's going to discharge you from therapy? Physical therapists are our colleagues, but at the end of the day, they're not meant to function independently. They're meant to function in conjunction, symbiotic with a physician. So having access to somebody locally is a good thing, to be honest with you.
Well,
and
and
so-
having been through your therapy department, I agree with Daniel. They're very good. They are just very good. And hats off to them.
And Dr. Southard, I'm sure you'll see this too. As someone coming in your clinic and they're basically just saying, I need a prescription from you for physical therapy for your physical therapy unit. And sometimes those can be the most simple things. But I find that patients do find it rewarding still, because oftentimes that physical therapy order, it's coming as a oh, we're going out the door at their primary care doctor's office and they're mentioning, the shoulder pain or their back pain. And so they're getting a quick order for the physical therapy, which oftentimes is appropriate, but patients also like it too, to really sit down, discuss the condition, get some more knowledge about what's going on, and then have a plan. So yeah, the plan may still be the same, physical therapy, but they may know, okay, if things aren't going well, I can get a cortisone shot in my shoulder, or I should take this medicine over that medicine. This is the prognosis for my expected healing time. The other thing too is, sometimes with the primary doctors, they're busy, or maybe they don't have it in their office. They don't have an x-ray there. And so I see a lot of patients going directly from, just talking with the doctor directly to physical therapy. And a lot of people benefit from really knowing what's going on under the surface. Is there bone spurs? Is there a cyst there? Is there something else funny going on? Before going on to physical therapy. So it is an inconvenience for some. And I feel for those patients, but I also try and see the positive of what they're getting out of that extra middleman step.
Oh, absolutely. That's exactly what I was tying to. I had one recently. A patient had a wrist fracture fixed up in New York. My professor at my medical school, surgeon is renowned. But they live locally. They're down here. They've had surgery by one of our colleagues in our practice in the past. They were comfortable. They wanted to have therapy here. So I'm not going to question this person's rehab protocol after countless numbers of wrist fractures that they fixed. So I do the counseling, like Dr. Becky said, talk to them, remind them, hey, look, they're your surgeon 100%, but we're around here if you need something. And then here's your prescription and on your way. And it's reassuring. It's, our job is to not only just treat patients, but also to guide patients, help them maybe see things in a different light. It's having those conversations with people and that one-on-one, the ability to communicate. I'm a firm believer that anytime a patient comes into an office or a consumer, so to speak, comes into the office, they should see the doctor. I know practices in various places that I've worked before where you only see the PA, you only see the NP. If that yes, sometimes post-op visits, you see the nurse practitioner, you see the physical physician assistant. Those allied health professionals, they're awesome. We need those people to function. But if you only see the nurse practitioner or you only see the physician's assistant every time you come in the door, that's not the way I practice medicine. And I don't think there's anybody in our practice that practices medicine that way either. Would you concur with that?
Yep. And I guess the most common, so we have a few, I guess you call them physician extenders now,
Yes.
PAs, nurse practitioners. So Dr. Powers and the surgeon's right-hand man in all of their surgeries is our PA named Jeremy. A lot of people know Jeremy. He grew up in this area, and I feel like I'm seeing a friend of Jeremy every day. And so the physician assistant is key in surgery and in monitoring the patients, after surgery in the hospital. And then here on the clinical side, we have our nurse practitioner, Rachel. And so she also, she does a lot of work with post-op and helping to answer patient calls that maybe a medical assistant or administrative assistant isn't as familiar with. So she really helps to bridge the gap. Sometimes she does see some of Dr. Powers' patients in clinic for those post-operative visits or those standard kind of boilerplate things. But I agree with you. The majority of our physicians are very hands-on, meticulous, and I don't see many of us kind of losing that control. Or we like to be in control of our patients. That may sound bad, but I think we just care that much.
No, that sounds great. Yeah. And Daniel's got a follow-up question for you. Daniel, go ahead.
Can you hear me this time?
Yeah, barely,
Yes.
but go ahead.
Yep, we can hear you.
Okay. I apparently could not hear anything from my last question. I turned on the radio and I could hear some discussion on that, but the issue was that I had a prescription, and it was from a neurologist, and my objective was to find out whether or not your therapy would deal with that kind of an issue. And seeing one of your doctors, they're not neurologists, so they can't give a second opinion on a neurologist's prescription. Yet they wouldn't let me check in with the therapy without seeing one of your doctors.
Yeah, it can be
That's
pretty
the Medicare. That
complicated.
gets back
Yeah.
to the Medicare
Well,
thing, right, Doc?
That yes, but sometimes there's a fair amount of overlap in neurological conditions and orthopedic
And
conditions.
here are the doctors.
Okay. Let me
Uh,
see.
Yep. So,
Daniel.
am I going through all right, Greg?
Try again, Doc.
Okay. So there is a lot of overlap with neurologic conditions and orthopedic conditions all the time. Sometimes we see things from an orthopedic standpoint where we're saying, yes, you have that neurological problem, but orthopedic specific physical therapy is still reasonable. Other times we see a patient whose neurologic problem is so overwhelming and dominating of their situation that orthopedic physical therapy is really not appropriate. And so in those times, we tend to recommend that the neurologist choose a physical therapy unit that is more specific, more familiar. They're experts of those neurologic conditions. Our physical therapists have a basic understanding of those things, but they're really more orthopedically focused. And so, if your neurologist said, yeah, you probably do fine in an orthopedic clinic and an orthopedic physical therapist, then he's probably right. You'd still want an orthopedic doctor to confirm that, because again, these things are complicated. And I'm sorry that you had to deal with these extra hassles here, but that may be why the system is built in that way. Maybe that's a little bit of background into kind of what's going on our end. What do you think, Dr. Southard?
Yeah. I think it to a degree, you're probably pretty accurate. I'm trying to, the few things that would cross over where, a neurological geared therapist versus an orthopedic geared therapist could be simple things like balance, gait training, things like that. If you're trying to
Parkinson's disease,
right.
We're
trying to strengthen the neuromuscular junction, neuromuscular function after, with some associated injury. Say foot drop, for example, you have a perineal nerve palsy, you have a foot drop, so you have to find a way to compensate for that. However, I don't think this is his problem, but our physical therapy is probably not the best place to recover after a stroke.
Oh, great point.
We don't have stroke rehab. We don't have, the type of environment where, if you have a true neurological problem that we don't have the equipment for it. There are facilities that are designed to do just that and just that alone. And to be honest with you, you don't want to be in the wrong place. If you're trying to recover from one thing and you don't have the treatment options for another. So there is that stop check where you need to be able to come in. Now, of course, there's Medicare regulations and so forth. But, that ties back into the role of the primary care physician. I know we're going to run out of time soon, but that primary care physician is a key point in the patient's care model. When PPOs came out and patients can go anywhere they want, for a short period of time, it became a real issue. Patients were just showing up to the wrong office for the wrong thing, wasting their time, not really wasting the physician's time, because any patient interaction where you're able to try to help somebody is not necessarily a waste of time, but it might not be the most efficient use of that patient's time. If I have a patient come to me with a straight neurological problem and they're sitting in front of the orthopedist office, or they have a medical problem and they're sitting at the orthopedist office, I can counsel them all I can to tell them that you don't have an orthopedic problem. They really need to see their primary care physician and have them be the quarterback, have them be the ringleader of everything, so they can get the proper care. And that's where it ties into the same thing: neurological specific rehab, cardiac specific rehab, post myocardial infarction patients. You're not going to come to our physical therapy place. We'd love to have you. We would love to help you. We just don't have the facilities to do that safely. We're not efficient at that. We're not safe for that. And you're better served going to a place that's what they do and that's what they do. That's pretty much as simple as I can probably put it.
Yeah.
Great point. Hopefully that helps a little bit. Does that answer most of your questions there? I'm sorry we don't have any better answers for you on why you couldn't come here.
Yes. Can you hear me?
Yes.
Yeah, we got you,
can hear
Daniel.
Okay. This is not a stroke issue. This was balance and gait training and some strength training. And the neurologist I specifically asked whether or not I could go to your therapy, and she says, "Yeah, you can go there." So, I had the prescription, I had the okay from her to go there, yet your therapist would not, or your therapy would not let me talk to them without going through one of your doctors first. And I don't, your doctors really are not qualified to feel or second guess that.
Yeah,
I think you're missing a point. I mean, it's second guessing is probably not the right term. I mean, our colleague that's on the line with us right now, Dr. Wisbecki, he's a musculoskeletal non-operative expert. He sees patients with your problem on a regular basis, and I know, point of fact, that he actually sends patients with problems probably like yourself to the neurologist.
Probably a dozen times a day.
Yeah, because like I said before with the PPO, I mean, sometimes patients show up in the wrong office with the wrong problem, and we're colleagues. Medicine, in theory, are colleagues. So, if you want access to the physical therapy place, and we have Medicare regulations that are preventing us from opening the door to greater than 10%, a guy like Dr. Wisbecki laying his eyes on you, giving you a simple visit, a once over an opinion, just so we can facilitate that for you, by all means, come on down.
Yeah,
All
Daniel,
right.
sorry, you probably missed this out, when we had the technical issues there, but we can only accept a certain number by Medicare standards, per year of outside physician orders for PT. And so that's likely the issue that we're dealing with. But yeah, it's very unlikely that I would contradict their orders. And so, yeah, come on in. If you want to see us at the PT, you just need a quick doctor visit, and then we'll get you on to PT. And all right. Sorry, Greg.
There you go.
Great
Okay.
show. And we'll see everyone next week.
All right. From Florida, orthopedic specialists, South and North.
Have a good one,
This
guys.
is Bone Talk. Have a good one, doctors. WPSL, Port St. Lucie.